Hello and good afternoon, everyone. This is the last session, so thank you for your interest and for taking the time to learn more about interventions for substance use disorders. On behalf of the Assistant Secretary for Mental Health and Substance Use, Dr. Delphin Rittman, I thank you all so much for your work with vulnerable patients. My name is Robert Baillieu. I'm a physician and senior advisor at SAMHSA. And in that role, I work on translating evidence-based practices into the clinical environment. It's a complicated role, and while a lot of people our esteemed speakers have described a lot of policy actions to date and many issues related to substance use disorder treatment, I'll today sort of gloss over some of my slides, so I'm not repeating what has been said, and nor it's not my wish either to sort of give you information you may already know. So that's one of the problems of going last in one of these sessions, because many of the issues have been discussed already. But please feel free to interrupt me if you have questions. I'm more than happy to engage in discussion. And I'm delighted to be here. I consider myself to be Southern, having grown up in the Southern Hemisphere. So I'm Australian, but now happily American, working for the US government. So today, like I said, I will very briefly describe the crisis as we understand it in the federal policy sphere, and then talk about policies and interventions that address the crisis. So certainly, as has been wonderfully described by our previous speakers, we're in a wave of fentanyl overdose and death currently. This doesn't occur in isolation, and we know from looking at various data sources, particularly from the CDC, the SUDOR system, which is very useful, demonstrates that much of the fentanyl is co-administered with stimulants. And with that, we see also contamination of other substances within the illicit substance supply. So this creates a lot of difficulty, not just in the treatment space, but in the policy space as well. We see a substance called xylazine contaminating the drug supply. And xylazine comes with many issues of its own. It causes skin lesions, it can cause impairment and many other problems as well. Certainly, stimulant use disorder is on the rise, and contaminating stimulants are fentanyl analogues. And so at the policy level, we need to think about interventions not just for fentanyl use disorder or illicit opioids, but also how do we address stimulant misuse? How do we fund systems of care that can potentially address this adequately? In addition to the issue of polysubstance misuse, which is something that we don't often hear about in these symposia. We talk about substance use disorders in isolation, but then many of these disorders occur in conjunction with others. And so we need to think about that, and then also think about the patient as a whole as well when thinking about paradigms of care. Certainly, when it comes to treating individuals, we know from looking at our own data, the NISDA data, that many people who have substance use disorders do not recognise the need to receive treatment. So that poses an issue for all of us as practitioners in talking to individuals about substance use disorders, understanding what it is they're using, and then designing patient-centred plans of care. But I'll get to that in the policy sense in due course. And I may not. Oh, okay. So the issue that we face at the policy level, the federal level, is that we have a really disorganised system of healthcare in this country. The patients, who should be at the centre of all our work, really are not able to enter the system at any given point. There are specific points at which they must enter care, at which they must engage all of you in order to understand how they could receive treatment. Our goal in the federal system, a very lofty goal, is to create coordinated systems of care where there's no wrong door through which a patient may enter treatment. This is a very difficult goal. This is one that requires funding, it requires coordination across federal departments, which is not easy, and it requires us to think about how we can work with all of you to better create those coordinated systems of care. Certainly, you know, that coordination comes in, and we had a wonderful question before about receipt of care or initiation of care in carceral settings. Certainly we have to work with prisons, we have to work with centres for Medicare and Medicaid services, and we've seen recently policy changes in this area, particularly around those re-entering the community after a period of incarceration, with changes in Medicare laws where individuals can receive Medicare prior to leaving a carceral setting, and that then makes them eligible for treatment moving forward. Within SAMHSA, the Substance Abuse and Mental Health Services Administration, we're one of 12 operating divisions within the Department of Health and Human Services. Our mission is to protect the mental and behavioural health of the population, and in doing so, we have 5 guiding principles and then underlying areas as well through which we work. Really important to us is a commitment to data and evidence. We can't create policy, we can't create funding initiatives without good evidentiary structures. We can't do this without understanding the scientific literature. We also need to understand evolving patterns of substance use as well. This is, as you all know, data has a lag. There's, 2, 3, 4, 5 years of lag in data. And so we need to think of modern systems. We need to think about how we could use artificial intelligence to better understand what people are looking up on the internet, for example. These are all things that, of course, take a lot of time, but these are things that maybe you'll be happy to hear we are thinking about at the federal level. Certainly, as I described, that's our Assistant Secretary for Mental Health and Substance Use, Dr. Delphin Rittman. We have different centres within SAMHSA, and unfortunately, like the healthcare system, we are somewhat siloed in our work. I work for the Centre for Substance Abuse Treatment, which is not a well-named centre. Certainly, it would take an act of Congress to change our name, and that's something that there are a lot of advocates for, and we welcome that advocacy. Certainly, we have centres for mental health, we have centres for statistics and quality, and we are starting to work together. We are starting to understand that there is a need along the continuum of care to better serve our patients, recognising that there are co-occurring disorders when it comes to substance use. People who have substance use disorders will often have mental health disorders co-occurring with that. And that complicates the treatment environment. It complicates the advice that we promulgate through the SAMHSA store, details of which I'll give you a little bit more, because when I worked in primary care, I had no idea about the SAMHSA store, and wish I did, because it has a lot of good information. Certainly, we also have our prevention centre as well, which is so important. We look at issues there related to harm reduction. We promulgate policy around naloxone distribution there as well, and we're very proud of the work we do for school-age youth in that centre also. While we have our own guiding principles and overarching aims, we're guided by higher powers as well. So we have the White House National Drug Control Policy. We also have our departmental HHS overdose prevention strategy. And these documents come together to help guide us and frame our work moving forward as well. Certainly, over the last year, there have been some really exciting changes to policy, which have been well described in the talks prior to mine. Certainly, the evidence underlying the MAT and MATE Act was an understanding by Congress that and we welcome removal of the data waiver. The data waiver served some purpose in providing education to practitioners as they dealt with a very vulnerable population. This recognised what the evidence tells us, that there are heterogeneous educational platforms across the United States, and that practitioners perhaps needed to better understand what substance use disorders were or are and how to intervene. And so this gave rise to removing the data waiver, but also promulgating systems of education, similar to what you're all engaged in now, to help better inform how we work with really vulnerable patients and how we provide treatment to them. So that's the MAT and the MATE Act. Certainly at the federal level, at SAMHSA, we are obliged in implementing these acts to work with the Department of Justice, the DEA in particular, which have their own system of control and regulations around different substances, in addition to specialty societies, in addition to state chapters, in better understanding how we can help. Of course, while MAT and MATE seek to remove the data waiver, that we recognise that at the state level there are laws that perhaps impede that, and certainly that comes down to federalism. While we at the federal level can make laws, there is no restriction on a state making a more heavy law around that area, meaning that, for example, and let me be clear, there are no now federal regulations around providing counselling prior to prescribing buprenorphine. That's the medication first model. However, some states will require that counselling be given at the same time. And so there are these differences which make sort of the delivery of treatment and understanding of systems of care somewhat complicated. And so when it comes to prescribing buprenorphine in this new world, understanding your state requirements is really, really important. There are some states still that have plans to continue a system of data wavering. And again, I'd like you to think of yourselves as advocates for your patients. There's nothing stopping you through your chapters, through your societies, representing to legislators at the state level to find consistency in laws between the federal and state level. So that's something to think about moving forward. Certainly, the other big sort of news item recently has been that the DEA has extended their sort of liberalisation of telemedicine laws that were issued during the COVID-19 pandemic. They've been extended until December next year, and this is to allow the DEA to create permanency in these rules. You may be aware that in February of this year, they issued a notice of proposed rulemaking, and they received a record 33,000 comments on that proposed rule. The proposed rule had a dual system, whereby there would be one system for Schedule 2 to 5 medications and another system solely for buprenorphine. This system creates stigma. A lot of comments commented on that. The difference in how we think about these medications is indicative of how some departments might think of treatment for substance use disorders and even the nature of substance misuse itself. And so, we're obliged in this sense to work with the DEA to really advocate for our populations. The other issue that was alluded to in the last talk was over-the-counter naloxone, and certainly the FDA has recently allowed naloxone up to 4 milligrams to be issued without a prescription over-the-counter. None of this happens straight away, meaning that while this rule is in place, manufacturers, pharmacy systems, state legislatures need to work to try and implement those laws. And so in the long run, we hope to see naloxone available over the counter to any population, to any person, and certainly that harm reduction intervention is really important. So that's another sort of evolving area. In terms of what we do at SAMHSA, we advocate for the work you do, we advocate for our patients, we collaborate with our federal partners, and we put forth information as well. Certainly we have our requirements for training for medication-assisted treatment as part of the MATE Act, and we've had a lot of engagement around that. The document itself really parrots the law, and a lot of professional societies have said, why weren't we included in the educational areas provided by the MATE Act? And that's Congress. Congress created the Act, and so we can't go beyond that, but certainly we can represent to Congress the need to make changes, and certainly they have the ability to do that, but nothing happens quickly in the federal system. It moves at a glacial pace, and so we do our best to try and expedite how this is sorted out. Certainly we have information within our website, the SAMHSA store. We have press releases that come out which provide information too, but I'll get to that in more detail moving forward. We also, as I said, work with our federal partners to reduce barriers. Like I said, we have this disorganised system of care, and so working to reduce barriers is really important. We know from looking at the evidence, both evidence from within HHS, particularly the UDS or Uniform Data Service from HRSA, that practitioners who work with other practitioners who prescribe buprenorphine more readily prescribe the medication. So in support of that, or recognition of that need for collaboration, we have the Providers Clinical Support Service, the PCSS, which is free, it's accessible. You can contact it to receive advice on prescribing buprenorphine, and you may have seen that we now have a notice of funding opportunity for a PCSS MAUD, so medications for alcohol use disorder, recognising that it is a complicated area and support is needed. So moving forward, we hope to fund activities in this area as well. And then beyond that, we have to think about stimulant use disorder, which I'll get to as well. Certainly, we've talked about, or previous speakers have talked about opioid treatment programs, OTPs. And in December last year, SAMHSA promulgated new changes to how OTPs operate. The changes to 42 CFR Part 8 represented the first change to OTP treatment standards, certification and accreditation standards within 20 years. These standards really included a lot of what we understand from modern evidence. The need to remove stigmatizing language, the need to remove restrictions or prohibitions on prescribing methadone when someone uses another substance. We recognize that people will use other substances while they're in recovery. That needs to be reflected in structures and systems of care, and so the proposed rule removed that prohibition, and the so-called 8 criteria were reduced to 6 criteria, and we really tried to incorporate harm reduction principles into OTPs moving forward. There are 7 carceral settings that have established OTPs of their own, meaning that these prison systems can prescribe methadone to their residents. Another, initiative we've tried to promulgate through SAMHSA is the use of mobile treatment vans. And mobile treatment vans were discussed within the proposed rule somewhat in depth, to the extent that these vans should be able to provide the full range of services that are provided in a brick and mortar OTP within the context of a mobile treatment unit. So we see many carceral settings partnering with OTPs by using a mobile treatment van. And certainly the proposed rule also talked about the initiation of methadone and buprenorphine using telehealth, because we know from that terrible natural experiment of COVID-19 that this is a safe thing to do, and we want to see that happen in practice. And so we also fund mobile treatment vans, so block grants from SAMHSA, which are $1.5 billion in grants to the states, can certainly fund mobile treatment vans for OTPs. So we're very proud of that intervention. And I should also say OTPs are here to help you as well. So in the age of fentanyl, it is difficult to treat patients who have illicit fentanyl use disorder. Their needs for treatment are higher. The medication needs are perhaps a little more intense. And so OTPs can help with that. They dispense methadone, which is often better indicated for people on high-dose fentanyl. We also have, I should say, the SAMHSA treatment locator as well. So the treatment locator is available through the SAMHSA website. And so many people say to us, it's difficult for us to think about what services we need to provide to our patients. And I completely understand that. Having worked in primary care across different settings, it can be difficult to sort of think about my patient in their plan of care will need X, Y, and Z. How on earth do I provide that? The treatment locator can help you. It does offer behavioural health service information down to the zip code. It offers addiction medicine referral services down to the zip code. It has many other other interventions for veterans and other substance use disorders too. So the treatment locator can be really useful if you feel that the condition may be too complex, and that is understandable, absolutely. Certainly, we also understand the issues related to workforce. Recent studies by SAMHSA and HRSA have shown that within the next 3 to 4 years, there'll be a 30,000 FTE deficit in the number of individuals who can treat substance use disorders and mental health conditions. This is something we need to address, and so HHS and SAMHSA have produced this workforce strategic plan, which seeks to move forward with training interventions, funding interventions, and really generating practitioners to work in communities who understand the community they're from and understand the cultural nuances of different communities as well. This is really important when it comes to thinking about how we best serve vulnerable populations. We also have a real emphasis on harm reduction. So harm reduction recognises that recovery is a personal journey. No one size fits all. And that individuals need different avenues to treatment and recovery. So when it comes to working with individuals, it is really important to recognise that their journey is their own and that we are there to help them on that journey. People may return to substance misuse, and that shouldn't count against them, of course. It should encourage us to work with them, to understand those potentiators of return, to work with the social determinants of health, and to think about how we help them mitigate any sort of potential harms from their substance misuse. So treating hepatitis, testing for and treating hepatitis, other infectious diseases, providing naloxone to individuals to discuss with their families the use of that, never using alone, and all of those important things that reduce harm in the long run. And, sorry. Technology is great, but can inhibit. So certainly, we at SAMHSA have promulgated this harm reduction framework, which is currently in the final stages of approval, and speaks to the need for practitioners to consider broader issues around treatment, very important issues, which provide whole person care. And then naloxone, so important in terms of reducing overdose. And we at SAMHSA have the naloxone saturation plan, which is part of our state opioid response program. SOAR, or State Opioid Response, is a $1.5 billion grant that goes to the states. The state is the grantee, and then the state delivers funds to sub-awardees within the state. So SOAR is really great at creating interventions and solutions that are appropriate for populations. And part of the SOAR grant requires states to think about how they can better deliver naloxone to populations. And so this means that we have to think about, in a quantitative and qualitative manner, how we can measure what states will plan to do and then what they will do and the outcome. And then that can help drive policy moving forward. So the SOAR naloxone saturation plan really is based in evidence. We initially required state grantees to tell us more about their plan, but we realised there was huge diversity in the information we got back. And so we then wanted to create a better structure, which led to work with our statistical unit and then engaging them in discussions and learning collaboratives so that states that demonstrated really good plans could work with states that may have had some trouble coming up with a plan. So this is information sharing and something that can help overcome really fractured systems of care. When it comes to naloxone and our state opioid response grant and tribal opioid response grant, we've seen great success with the use of naloxone. Almost 500,000 overdoses were reversed. We've shown that there is evidence for this. We've shown efficacy. We've also shown economic impact as well, which is really important to policymakers, which is sad, but certainly showing community benefit, not just in lives saved, but also an economic return is really important. So our SAW-TOR program seeks to promulgate distribution of naloxone through the saturation plan. Beyond this, when we think about systems of care, we have to think about stigma. And certainly, we are responsible, in part, for this stigmatized system of care. At the federal level, the creation of the data waiver, opioid treatment programs, although we've tried to liberalize them, and many other structures and regulations around the treatment of substance use disorder do not help. And so in working with patients with substance use disorder, it is just a chronic medical condition and requires person-first language. It requires understanding. It requires a recognition that individuals may not always be compliant with their treatment, and that shouldn't count against them. It's like a diabetic using insulin. They won't use their insulin every day. They will certainly eat cake now and then. And so working with individuals to understand the motivations behind return to substance use, and working to also overcome those motivations through counselling, through overcoming adverse social determinants of health, and interventions like that are really important. And many of our grants at SAMHSA help different sites to work in that area. So we have the Minority AIDS Initiative, we have Bureau of Prisons grants, which all work in this area to provide funding for case management for social workers and all of those other really important things that provide whole person care. Certainly, like I said before, we recognise the need to provide a collaborative approach to care. And so at SAMHSA we have a lot of free, all of our resources are free. We have the Providers Clinical Support System, which currently focuses on MOUD, but will in the future expand to alcohol use disorders as well. We have the sort of technology transfer centres. We have the ability for states to seek TA through the ATTC networks so that they can provide better interventions for their populations and ones that are targeted to their specific needs as well. So this is our sort of practitioner training portal, which you're all welcome to access. It's all there for you to look at and to use as appropriate as well. We also have a lot of our guides also, so on the SAMHSA store, these are all available for free. They incorporate evidence and best practices and are written with technical expert panels to help you, the practitioner, deliver evidence-based care. They are quite lofty. Some of them are up to 400 pages. And so to help overcome the inertia of going through those documents, we have advisory documents as well. The advisory documents are 10-page documents that really give the crunch, the highlights, what you need to know, and can help you think about how to integrate whole person care that is evidence-based and up-to-date into practice. So that's available through the SAMHSA store. Similarly, as I mentioned, we have the findtreatment.gov link on our site, and this link is going to be, it's really important and very helpful to the extent that it does reveal down to the zip code where to find counselling, where to find addiction medicine specialists, OTPs, how to engage different practitioners across the continuum of care. So this is a really helpful resource that I wish I knew about when I was practicing in primary care, because it is very, very helpful. Beyond this, when it comes to working with people in the outpatient and office setting, we at SAMHSA are starting to realise the importance of better engaging. So recently we produced a specific guide for primary care. It does reference the data waiver several times, which is incorrect as of December 29 last year, but the general information about initiating buprenorphine, the lab testing that needs to be done, the use of person-centred language, it's all in this book. It is very specific to the primary care environment in terms of collaborating with pharmacies in your community to ensure that they stock buprenorphine to ensure that they have supply to provide to your patients. Tips and techniques to help successfully implement buprenorphine prescribing. And this is really important because research tells us, we've gone over this, research tells us that there are people within, so there are a large number of people within practices who have an opioid use disorder without necessarily revealing it to you. We know that generally in a panel of about 1,900 patients, there are 19 of those patients who have an opioid use disorder, and only 4 of them are currently receiving treatment. That's not an indictment on anyone here, it's an indictment on the system. It indicates a need for us to implement universal screening. It's okay just to ask the patient, what are you taking, if anything, using person-centered language, non-stigmatizing interactions. And over time, a patient will reveal different aspects of their life. And certainly that's an introduction to start to think about how to better engage individuals in treatment. Harm reduction will say that creating collaborative plans of care, not forcing an individual down a particular path, is really important. So introducing the idea of treatment, introducing the idea of counselling, talking about testing for infectious diseases, and working with the individual to think about other approaches to mitigating their substance use, and ultimately, hopefully thinking about coming off of that substance and going on to treatment. Certainly, I'll just go back here and say that within the continuum of care, it's not just treatment we need to focus on. There's prevention, there's early intervention. These are all things that we need to think about as practitioners when it comes to managing individuals with substance use disorder. So in a World Child Visit, talking with the child about any substance use they're engaged in, but also the family substance use, their family dynamics, thinking about those adverse events that may precipitate substance use in the future. These are all interventions that are really meaningful, that are really important. And it's not just treatment that we should focus on, it's these other areas that really underlie substance use disorders. So thinking about how this could work moving forward. Certainly, we've looked at much of the evidence underlying receipt of MOUD and MAUD, but in each case, there's a knowledge to treatment gap. And so certainly at the federal level, that requires us to think about how we overcome that gap. So creating collaborative structures like the PCSS, promulgating laws where we can, and SAMHSA really only has jurisdiction over 42 CFR Part 8 and in Part 2 as well, which is the privacy and confidentiality law. But that is moving to the Office of Civil Rights. And so thinking about how we at the federal level can engage different federal partners to create more collaborative care structures. And so certainly we know that those who need treatment for opioid use disorders are not necessarily receiving that treatment. Whether it's provided in your office or you refer out, that's okay. As long as you're asking the patient and understanding how you can help them in the shorter, medium and longer term, that's going to be the really important intervention. Case finding. When we think about expanding access, a lot of times, and particularly from the DEA, we hear, oh, but buprenorphine's diverted. But we understand from the evidence, and we can show that this is not the case. It's not diverted for recreational purposes, it's diverted for the purpose for which it's intended, which is to mitigate withdrawal. It is certainly, diversion is an indicator of need. And we know that among those who receive diverted buprenorphine, they're more likely to engage in treatment. And so diversion, while on the surface is not a good thing, it's an indicator for us to work harder, to think about how we can engage you and how we can engage systems of care to expand access. Certainly the DEA would disagree with us, and they're looking for ways to monitor prescribing of buprenorphine. They're looking for ways to monitor different prescribing actions. And so one of our roles is to work with them collaboratively to provide them with a practitioner perspective, to advocate for vulnerable patients that perhaps this isn't the right way forward. Certainly, we've learnt about the importance of medications for alcohol use disorder, and certainly MAUD suffers similar issues to MOUD. There's a lot of stigma, there's a lot of misunderstanding and heterogeneous platforms of education which really complicate delivery of these medications within the office or primary care setting. But the other thing we need to think about is stimulant misuse, because like I said, the illicit fentanyl overdose epidemic is driven in part by polysubstance misuse, or it is a sort of illegal contamination of a primary substance with fentanyl. So the individual using methamphetamine, for example, won't necessarily know that it's contaminated with fentanyl, and that can lead to overdose because of low tolerance. Certainly at SAMHSA, we allow SOAR funds to be used for the purchase of fentanyl test strips. Fentanyl test strips save lives. And so just encouraging an individual who may potentially encounter fentanyl to use a test strip is going to be really important. Previous administrations have felt that that is not particularly cognizant, but we've seen through evidence that this is changing. We understand that individuals want to preserve their life. And so fentanyl test strips are really important to distribute and to fund. So that's what SAMHSA does. Certainly, we know that the treatment of stimulant misuse, which is on the rise, is difficult. There are no FDA-approved medications for stimulant misuse. That being said, NIDA's treatment laboratory is looking into different types of medications to help. But in the interim, there are only psychosocial interventions. The best one is contingency management. Has anyone heard of contingency management here? No, that's okay. So contingency management is founded in the sort of conditions of operant conditioning. So it essentially provides rewards for people who provide negative urine samples. So this then rewards the pathways in the brain, and over time they start to sort of move away from substance misuse. Contingency management is evidence-based. Contingency management can entail up to $700 or $1,000 in non-cash equivalents being distributed to the individual. At the federal level, there was misunderstanding about guidance from the OIG, which is the Office of Inspector General, which limited federal funds for contingency management to $75 per person per year. This has proven really problematic because a misunderstanding at the OIG federal level has seen federal funds really not support this really important intervention. We're trying to change that, so HHS is working to understand the evidence underlying implementation of contingency management. I recently hosted a summit with educational experts around how to better implement evidence contingency management, and we're working with OIG to create safe harbour rules around contingency management. This all takes a long time to implement, but it is something we recognise as being really important. So addressing stimulant misuse head-on is a real priority for us moving forward. This is particularly important because of the issue of polysubstance misuse, and we know that these individuals will not use substances in isolation. They will not just have a substance use disorder, they'll have co-occurring mental health disorders, derangements and social determinants of health. And all of these things need to be addressed, which can be overwhelming in the context of a 15-minute appointment. So certainly that's why I mentioned the treatment locator. That's there to help when it comes to tailoring treatment plans to individuals. The issue of polysubstance misuse is really important because those who use alcohol and marijuana concurrently have a cumulative effect, and often these individuals will drive, which can lead to drugged driving and accidents. And we know that individuals who have both substances on board are more likely to be involved in fatal accidents and cause morbidity and mortality to themselves and to others. Certainly this table can be found in our guide called Treating Concurrent Substance Use Disorder. So this guide is really interesting because it considers, for not the first time in literature, but brings together a lot of the nascent literature in this field into one book to think about how we address this evolving problem. And certainly it is really important. Like I've said, it affects many individuals, particularly young individuals. It causes mortality and morbidity, and is really addressed through a combination of medical treatment and psychosocial intervention as well. This book is available for free, of course, in the SAMHSA store. And it really talks about the issue I talked about initially, which is the hindrance of fragmented systems of care. So this was a real wake-up call for us in terms of trying to improve how care is delivered, how we can work with states and you to better understand how we can do better in terms of funding better systems of care. Certainly, polysubstance misuse poses significant challenges around treatment planning. It is complex. It is discordant. Everyone has different needs. Everyone has different social determinants of health that need to be addressed. So this really complicates how the intervention may occur. We know from the evidence that things that don't necessarily happen are really important. So co-location of treatment activities, that combined with FDA medications, contingency management is really important. And contingency management doesn't just work for stimulant use disorders. It has evidence for tobacco use disorder, for any other sort of use disorder that requires abstinence, but also contingency management has a lot of evidence for treatment attendance as well. So that we need to really work hard to better understand how at the federal level we can upregulate and bring this intervention to scale. Certainly, we need to sort of consider within the context of polysubstance misuse how we can help you, the individual practitioner, how we can better support through funding, through evidence-based publications, and through grants, the delivery of care that is comprehensive to address an evolving crisis. And it is not a static crisis either. At the moment, we face illicit fentanyl. Tomorrow it may be something else. We're seeing xylazine becoming more prevalent in the supply, and xylazine poses its own problems as well. So evolving issues are things we need to focus on at the federal level also. But with that, I'll say that we rely heavily on evidence. We rely on qualitative and quantitative evidence. And what you tell me and what you tell the federal partners is qualitative evidence. So that's why it's really important that we engage, that we hear from you, and that you as individuals who thankfully look after vulnerable populations interface with us at the federal level and state level, advocate for change. Certainly, we have to think about the continuum of care. We have to engage in prevention activities, not just treatment. Tertiary interventions are great, they're important, but prevention is better than cure, as they say. We at the federal level need to think about how we can bring treatment modalities together, how we can house them in singular areas. And certainly CCBHCs, or the behavioural health centres that are funded by SAMHSA and some states, attempt to do that. They're not perfect. They certainly need to provide more medication interventions, but they're getting there, and they act as an interesting model for further study, for better understanding how we can elevate the treatment of co-occurring disorders, polysubstance use within the community. But most importantly, placing the individual at the centre of our work and thinking is the key. Understanding that everyone is different, understanding that everyone's recovery journey is different, and thinking about how policy can elevate that, support it, and work with all of you. So with that, I thank you for this opportunity to walk you very quickly through federal thinking and policy planning, and I invite any questions that you might have. Thank you again.